Good afternoon, everyone. My name is Michelle Oshman, and I lead patient advocacy here at BIO. And today we have an exciting conversation planned. You may have noticed that our invitation to today's coffee chat was a little bit tongue-in-cheek. And I said, looking for topics to discuss at the Thanksgiving table that aren't about the elections? Well, look no further, because it's time to see whose pockets are being stuffed, the PBMs. So we're going to have an interesting conversation about pharmacy benefit managers, the role that they play in terms of patient access, and what some potential reforms on the horizon might look like. So I have three wonderful speakers today. Anna Hyde, who is the Vice President for Advocacy and Access at Arthritis Foundation, Brian Connell, who is the Vice President for Federal Affairs at Leukemia Lymphoma Society, and Patrick Wildman, Pat, Senior Vice President for Advocacy and Government Relations at the Lupus Foundation of America, and also the lead convener of the MapRx Coalition. So with that, let's kind of jump right in, and I'll start with you, Anna. When you're talking to your grassroots, how do you talk about PBMs, and how do you engage the grassroots on the issue?
Sure. Thanks for having me, Michelle, first and foremost. I think there are a lot of different ways to talk about PBM reform, of course. It's a very big topic. And so I think for us, what we've tried to do is kind of break it down into the top kind of 3 or 4 component parts that are most relevant to our patient population. A few years ago, the FTC, Federal Trade Commission, was looking for comment from patient community on kind of how certain PBM policies impact patients. And so we decided to take those questions and turn them into a survey and asked our patient population, kind of how are you impacted by things like mail order pharmacy? Are you required to use a mail order pharmacy? Things like that. So that was really helpful because we were able to then feed the data back and make it an essential part of our grassroots now. So it's really sort of over the last few years, we've been able to say, 50% of you told us that you're impacted this way by this particular PBM practice. So that's kind of one way, is just to make it really relevant to them. And then there are certain kind of issues like step therapy and prior authorization that really hit home for our therapeutic area in particular. And so we roll those in as well, sort of under the broad umbrella of PBM. So those are just a couple of ways.
Yeah, thank you for that. How is Arthritis Foundation taking on the issue, sort of big picture? What is your advocacy agenda as it relates to PBMs?
It's evolved a lot over the last couple of years. I think we've come a long way. In the beginning of this Congress, we were sort of looking, like a lot of people, to sort of hitch a ride on the broader PBM reform wagon. But we were really hyper-focused on a couple of pieces of it. Step therapy reform, which I already mentioned, in the form of the Safe Step Act, which remains one of our top priorities. And then some other kind of PBM initiated practices like accumulator adjustment programs and the Help Copays Act that addresses that issue. So those are kind of 2 hyper-focus areas. In the last year, though, we've evolved a lot as we've seen this Congress kind of dwindle in time. And really in the last month in particular, we've worked with a lot of other patient groups, including those here, on really supporting the broader umbrella of PBM reform. So really saying transparency, delinking fees is another one, banning spread pricing. And then of course we want, Safe Step Act as part of that, but we know that the best way to get Safe Step reform done is through this broader vehicle of PBM reform. So we have really broadened our tent in terms of supporting PBM reform overall, even if there are a lot of pieces within the broader reform packages that we don't really have a position on.
Sure. Okay. Thank you so much. That's really helpful. As we've seen these increases abuse in step therapy, really one of the things that we've heard from providers, in particular in the arthritis or rheumatology community, so certainly this affects Pat as well, is sort of the complexity and the amount of time their staff have to spend on that. So can you talk a little bit about what are you hearing from the rheumatology community or other provider communities about the amount of time they're spending on prior authorization, but ultimately that gets down to step therapy as well?
Sure. We know from talking to rheumatologists over many years now that the burden of managing prior auth and step therapy is very intense, that a lot of practices are having to hire office staff just to manage through prior auth and step therapy. The rate of prior auths and step edits are growing. And it's not just that more drugs are, or more are getting caught up in the step therapy process, it's the number of step edits that are required. So sometimes it can be, 2, 3, even more. And some of the survey data that we have collected from our patient population over the past few years really corroborates that. So between that and then other sort of provider surveys that have been done, we know that it is one of the top administrative sort of burdensome issues that rheumatologists face.
Thank you so much. I'll turn to Brian now. Brian, you just heard Anna talk about the multiple components of PBM reform that are important to all of us. But as you think about Leukemia Lymphoma Society, what are the provisions that you would say your patient population is most concerned about?
Yeah, no, thanks. And thanks for having me. And I'm excited to talk about this today because there are so many important pieces for blood cancer patients. We represent the 1.7 million Americans with a blood cancer diagnosis. And from our space, there are lots of ways to treat a blood cancer, but most of them do involve pharmaceuticals. And those are often highly priced pharmaceuticals. Those are the ones that PBMs are really focused on trying to manage utilization and really tamp down utilization of those drugs. So our patients are often caught in the middle. What we've seen, one of the things we've talked about a lot with PBM reform has been first and foremost spread pricing, but almost as an example of the problem rather than a reflection of the whole problem. But just an example of spread pricing in blood cancer, we've had a drug called Gleevec and off brands called imatinib. That was a drug that came off patent just a few years ago. And as it was coming off patent, the cost of that drug really fell dramatically. So you saw a price that went down below $100. Meanwhile, the PBM was actually still charging, this is just in the case of Ohio Medicaid, was still charging over $300 for that drug. And so they went from a very tiny margin to an enormous margin. Meanwhile, the Medicaid program was still paying a lot and patients weren't getting any benefit at all. And so we've seen that not only in the Medicaid program, but also in the commercial market. So that's one area where we see patients being the victim of this, is where PBMs are using kind of the black box of the payment system to siphon off a lot of savings for themselves and not pass on that savings to patients. And so we think spread pricing is important, but really connect it more broadly to delinking the drug price with the compensation that the PBM gets. And so we think that's a way to address this broader problem. It addresses spread pricing and other kind of similar challenges. And then also, we would encourage Congress to think about how do you pass along all the savings that PBMs negotiate that, in a more transparent system. How do you pass that along to patients so that patients who struggle to access their care because of the costs are actually able to experience that savings and then have better time accessing the care that they need?
Thank you so much. Yes, I think about the delinking component and think about the original intent of the sort of the industry of PBMs was we started off with a system in which there was simply an administrative fee, and then over time saw that some entrepreneurial companies started tying this to the price of the drug, and then of course we've devolved into spread pricing. Earlier today, I just ran the Fortune 500 of companies here in the U.S., and in the top 50 are all three of the primary PBMs in the country that cover about 80% of our market. And if you include Humana as the fourth one, we're really talking about closer to 85-90% of the market. And all four of those companies are in the top 40 actually. Highest value companies in the U.S. So it tells you a lot about where the money is going when you see all four PBMs listed in that top 40 and not a single large pharmaceutical company, with the exception of J&J, which of course has dozens of component companies. So Pat, I'll turn it over to you for a minute here. You've been leading the MapRx Coalition for a number of years. I think a lot of folks on the line are familiar with it, but if you don't mind just telling us a little bit about MapRx and what you've focused on over time and how you're working in the PBM space.
Sure. Thanks, Michelle, and appreciate you having me this afternoon. So the MapRx Coalition was created by the Lupus Foundation of America back in 2005, so right before Medicare Part D was implemented in 2006. And the focus back then was to ensure that the new benefit, the prescription drug benefit, was implemented in a way that was patient-friendly and really meeting the needs of Medicare beneficiaries. Since that time, we've really focused on expanding our reach. So we have over 60 patient groups as members of MapRx, and that continues to grow. And our goal is to, again, preserve and protect Part D, strengthen it, and make sure that patients have access to the medications they need. And some of the issues that we focused on really dovetailed very nicely into this topic. And Anna and Brian have mentioned some of them already. And a lot of our focus has been on things like utilization management and the challenges that patients face when it comes to whether it's prior auth, whether it's step therapy, and those challenges that create barriers to the medications people need. So MapRx certainly has been focused on those, not only with PBMs, but also a number of other issues that are out there, not subject of this discussion today. But the PBM issues are certainly relevant to everything that we're doing as a coalition, and very relevant in lupus specifically, and I'll kind of talk a little bit more about that. Our patients take on average 8 medications, so access to drugs is really, really important to help people manage their disease and to improve outcomes. And any barriers, whether it's step therapy, whether it's choice of pharmacy, which is one of the challenges with PBMs, any barriers to care can lead to worse outcomes. And what we're trying to do is in this debate is really humanize it, show how these policies impact people living with the disease. And when we're going to the Hill, it's really showing members of Congress how these impact their constituents, whether it's access, whether it's affordability. Brian was talking about how can we get some of these savings back in the hands of patients. That's a huge focus of ours. And that's probably one of the biggest barriers that people with lupus face is affordability. And PBMs really don't help with that, and nor do they help with the access part. They create barriers to access. So that's a lot of our focus, both with LFA as well as the MapRx Coalition.
Got it. Thank you so much. And how do folks get involved in the MapRx work if they're interested in being part of that?
Sure, they're welcome to reach out to me, and Michelle will share my contact information. We welcome any patient group to get involved. And the more voices we have, the more perspectives that we can bring to these issues, the more effective we can be, both on the Hill and importantly with CMS.
Thank you so much. We came up with a whole list of questions for the panel. Because we're recording today, we're not actually going to be taking live questions, but I think we've come up with a good list of questions. And if anybody on the line does have a question that is not answered today, go ahead and send a chat over to Swapna, and she'll make sure that we can follow back up with you. So you've all talked about step therapy and the pain and the frustration involved in that. And one of the questions that often comes up when I think about this medically complex patients is the role of specialty pharmacies. So I guess it's for all of you. What are some of the challenges your communities face with regard to specialty pharmacy access to medicines that are delivered through that mechanism?
Well, I suppose I'll start. Certainly, I think the vast majority of our patients do receive their medications, at least biologic therapies, through specialty pharmacies. I think that most have a pretty good experience with the specialty pharmacy. I mean, they have this sort of expertise and training to manage really complex drugs like biologic medications. That said, there can be logistical issues mostly is what we hear. So sometimes, through your specialty pharmacy, it's often mail order, and sometimes something gets misdelivered or delivered at a wrong time. And, some of these medications need to be refrigerated. And so that leaves patients wondering, what do I do, with this? Is it okay to still use? Things like that you may not think about. But when you talk to patients every day, those are the sort of logistical issues that people hear about. If you're traveling, we've heard lots of sort of concerns from people who are traveling for extended periods of time, and what do I do if I have a very specific sort of like geographic location that my specialty pharmacy is tailored to. And I think the bigger issue that Pat just alluded to a few minutes ago is this sort of steering of patients to very specific pharmacies. So it may be that you've used one pharmacy for many years, you really have a relationship, you really enjoy that relationship, and you have good service there, and then all of a sudden you're required to switch to this other specialty pharmacy. Oftentimes it's tied to the PBM that you're using, and you don't have that choice anymore. And I think that causes a lot of problems for patients as well.
Yeah, and I'm interested what folks' perspective on this, but the FTC report talked about sort of this vertical and horizontal integration, I guess you might say, or devolution from a patient perspective, but that in an effort to streamline business practices or services, PBMs now have their own specialty pharmacy, at least the top three plus Humana do as well. And so again, this patient steering, it sounds like, is a real challenge when patients are steered toward a specific therapy because of that, that the interest that PBM has in that. What about you, Brian or Pat? What are some of your thoughts?
Yeah, I'll just jump in to say, in addition to what the issues that Anna flagged, I think one thing that we're seeing as we see that consolidation, and we have your PBM potentially being the same, or owning your specialty pharmacy and owning in Part D probably your Part D plan. And so you have this same entity in control of like all different aspects of this due to consolidation. And so we have in blood cancer, I'm really concerned about, we're excited about this brand new innovation coming January 1st of having a $2,000 cap in Medicare Part D, and to have the potential to smooth those costs over the year so that you don't have to pay that $2,000 all up front. But we know that a lot of folks don't know about this new benefit. The benefit's kind of complicated, the smoothing part in particular. And so patients are going to need to talk about, is this the best option for me? Folks who have been on low-cost drugs before and they have a really terrible diagnosis, and now they have to be on a more costly medication, have never probably contemplated this even in the years coming. And the place they're going to turn is going to be the specialty pharmacy, who actually is also owned by the PBM, who actually loses money if they actually adhere to their therapy as would be clinically appropriate. And so we're really concerned that the place who they're going to turn to for information about this new smoothing benefit in Medicare is going to be the people who are actually least inclined in terms of incentives to actually offer them help in understanding that benefit, and then to enroll in that and actually really reap the financial benefit of that new, really exciting new protection. And so I think that's one example of many of the challenges when you have all the vertical integration within the PBMs and the plans and the pharmacies, where the incentives are designed for a system we don't have anymore. And so we have then incentives that are not patient friendly that are baked in.
Thank you for that perspective. And in terms of that consolidation, you even look at healthcare providers, at least for, again, the top three that really have their own provider network, Minute Clinic and others. So significant interested parties, I guess I should say. And where is that sort of conflict or challenge? So when you think about PBMs and PBMs driving sort of different marketplaces, I'm curious from all of your perspective, we're now hearing about pharmacy deserts, as it were, in rural areas in particular. And I wondered if any of you have heard from your patients about that challenge and kind of what it means to your community.
Yeah, Michelle, it certainly is an issue for us, and it's something I mentioned right at the outset, and it gets into patient choice. And that community feel, and Brian was just talking about the smoothing benefit with Part D and the important role that pharmacies play. And so that's one element of when people are steered away from a community pharmacy. That's a challenge, just that personal connection and that ability to get more information to help guide someone's care. But it comes down to just to what's best for the patient. And that flows into things like step therapy and choice of medication, and on those issues, and this is one of the big concerns that we have is no two patients are exactly alike. The practice of medicine isn't a one-size-fits-all proposition. So the consolidation in the industry and the vertical integration, presents challenges in really the practice of medicine, and in ensuring that patients get the care that they need specific to their condition.
Yeah. So with lupus in particular, I think about, you said the average of 8 medicines, I think you stated. Yeah. Mm-hmm. Can you talk a little bit about the medically complex lupus patient and the different specialty providers that they need to see? Sure.
Yeah, so lupus is a very heterogeneous disease. There are 3 main types of lupus. And let me back up a little bit. It's a very challenging disease to diagnose. It takes about 6 years to diagnose it because people can confuse it for many other conditions. But once there is a diagnosis, the disease can manifest itself in different ways, whether that's skin, and that's probably one of the more common ones that people see because you can see it in the skin. But there's also lupus nephritis where it's impacting the kidneys, and systemic lupus. And lupus can really progress to impact any organ in the body. And it differs among different people. So that presents a huge challenge with the disease. And another thing I just want to point out about the disease too is it disproportionately impacts women of color. 90% of people with lupus are women, but again, women of color are 2 to 3 more times likely to develop the disease. And so we want to make sure that as people are treated, regardless of who they are, that they're getting the medications that are specific to their care, whether it involves the kidneys, whether it involves the cardiovascular. A lot of different impacts of the disease, which require different medications for different people. And so making sure that people have that access and their physicians have the ability to prescribe and that they can obtain their medications from a pharmacy that's close to them. And that can, not being able to access pharmacies is a big challenge too, it adds to some of the health inequities that we see. And it's also part of the social determinants of health. People don't have ready access to a pharmacy of their choice. The option creates an affordability challenge. Then we have certainly leads to worse outcomes. It does not lend itself to adherence to medication. So a lot of different challenges that we're faced as a community.
Thank you so much for that perspective. And when we were at your corporate council meeting, there was so much conversation about step therapy again, and really some of the egregious practices, taking, if a patient switches plans or if they're shopping for their Part D plan for next year, they may or may not see their current medicine on the formulary, and they may be switched back to something as archaic as drugs approved 50 years ago. So can you talk a little bit about how that affects your population?
Yeah, that's the huge challenge. In lupus, as you mentioned, for a long time, we haven't had medications, and the treatments that were available for lupus were approved 50 years ago for other conditions. But recently we've had new treatments developed specific to lupus, both lupus nephritis and systemic lupus. We have a lot of treatments in the pipeline, and we're expecting, with that promise, with the opportunity to have new therapies on the market, and the ones that are existing, great opportunities to treat the disease. And we're very, very concerned about what the access part looks like. Are people going to have access to these breakthrough medications? Are they going to have to step through old therapies to get to them? And we saw that right out of the gate, just when we've had more recent, in the last 5 years, we have 2 new medications on the market. And there were requirements that you have to fail in standard of care before you can get to one of these medications. And that creates real life problems in terms of outcomes. People's disease can progress to significant organ involvement, and ultimately, when it comes to the kidneys, eventually a kidney transplant. So there's huge ramifications from a health standpoint of barriers to access, like step therapy or even prior auth, which can lead to significant delays in accessing treatment.
Thank you. Anna, coming back to you, when Pat talked about the heterogeneity of lupus, as Arthritis Foundation, you represent patients with a number of different diagnoses. Are you seeing greater challenges with sort of these PBM-driven step therapy or access challenges in specific components of your community versus others?
We definitely see more challenges for the sort of autoimmune patients, those with rheumatoid arthritis, psoriatic arthritis, ankylosing spondylitis, those kinds of conditions. And particularly, I mean, similar to lupus, it can take a long time to get diagnosed. Once you get diagnosed, it can take a long time to get on the treatment that you need. So that's where we really see problems. If say your doctor believes that a particular therapy is going to be best for you and you want to treat early and aggressively to prevent worsening of disease, your PBM may require stepping through 1 or 2 or 3 other medications before you can get that one. And it's not like you can try one, realize that it doesn't work a couple weeks later, and then immediately shift to another one. There's a process for that, and it can take many months. And in that time, we know from survey data that we've collected that you can experience significant worsening of disease. So that's one reason that we really support the Safe Step Act, because it doesn't necessarily do away with step therapy. We're not saying that, PBMs and payers shouldn't be able to use utilization management, but that there should be appropriate guardrails to make sure that we don't see those adverse, health outcomes.
Thanks for that. Can you talk a little bit about the Safe Step Act and sort of what we're seeing at the federal level, but also at the state level in terms of the coalition that you all are co-leading?
Sure, absolutely happy to. So the Safe Step Act has been around for a few Congresses now, and really, it's built off of a model that was first introduced at the state level. We've had a lot of success at the state level. We've had, I think, nearly 40, give or take, states that have passed some version of step therapy reform. And then a few Congresses ago, we were able to get it introduced, sort of a version of that. And like I said, common sense guardrails. It's, if you're stable on a medication, you don't have to come off of it to step through something else. If you change insurance plans, for example, if you've failed on something before, you don't have to fail on it again. Reasonable time limits for, filing an exception, things like that. So that's essentially, what the bill does. We've built a lot of support over the last few years. We have over half of the House co-sponsored on it, and a number of members of the Senate. And interestingly, this year we've got a little bit further than last Congress in that the Safe Step Act on the Senate side is included in the Help Committee's PBM reform package. So that's part of the reason why we think that PBM reform, passing it sort of writ large, is really important, because we've already sort of got the vehicle there. So that's really what we're hoping for. It remains our top legislative priority, and we think that it can really streamline a lot of these sort of practices that are causing a lot of harm to patients now.
Thank you. As some of the, at the state level, a number of PBM bills have come up and really looking to rein in sort of this the conglomerate that PBMs have really become. And it seems like there's been some creative drafting at the state level, or creative linguistics, I would say. We're seeing that PBMs, rather than referring to rebates, which of course is the rebate structure that we always talk about, referring to some of these financial transactions as surcharges and discounts. So again, I think as you all work to address the issues that PBMs bring forward, we're also seeing some adaptation on the PBM's part to sort of use creative nomenclature, which again is a frustration, certainly. I'll turn to you, Brian, and talk a little bit about, again, when I think about any disease area, but in particular the blood cancers, when days really matter, and getting on a treatment within 1 week could mean the difference between life and death for somebody who could have otherwise been on it in 48 hours, say. Do you have a sense of what your average time lag is for patients if they are prescribed something other than what the PBM lists as their preferred medicines?
I think it differs a lot. And heterogeneity in our space looks like, the average blood cancer, about half of our patients are over 65, but we also have the most common form of childhood cancer. So we have folks who are pediatric patients. We have a lot of kind of adults, but under 65-year-old patients. And then we have, certainly a lot of patients over 65. So they all have various different interactions with the system. And some of them are inpatient for months or even years. And some are, seeing outpatient, and so there's a lot of variety. But we do see a crisis in our space when you have delays. Patients who are really like pediatric cancer families will talk about how they're driving home from the doctor. There's still this concern about my kid is sick. I'm not sure what it is, but it's getting worse. And they will have taken a battery of tests. They're heading home, and literally in the car, they get the call from the pediatrician or pediatric oncologist that says, you can't even go home yet, turn around. You need to turn this car around, you need to get back because we need to get you on therapy in the next hour or 2 hours. That's how time sensitive the initiation of therapy needs to be, particularly for the acute leukemias, but across a lot of our diseases, because every hour wasted is an hour that really impacts the patient's quality of life and ability to keep fighting. So, we really can't rely on there being any buffer there in terms of the distance between when a necessary therapy is prescribed and when that therapy actually gets to the patient. So we do have a lot of concern, particularly with prior auth, but also step therapy there too. But prior auth is ubiquitous in oncology, and so we see those practices of different types of utilization management really presenting a lot of patient harm when you have patients who need access to that therapy and they need it immediately, and that's delayed with the assumption that these are some hoops that need to be jumped through. And certainly doctors have folks who are on staff, and they're spending money for that, to have folks on staff to jump through those hoops, but each one of those hoops takes a lot of time. And so that's an extreme frustration for blood cancer patients. I think a lot of patients, even beyond blood cancer, and that's what we see a lot.
Such a frustrating situation, and certainly here cancer and so many other areas as well, but in particular cancer, the cells mutate over time and can sort of quote unquote outsmart the therapy that they're on. So when what behaviors are you seeing if a physician needs to advance to a new treatment or switch treatments? Is that something that's pretty seamless, or is there a step therapy protocol that could be embedded there as well?
Yeah, there are a lot of challenges for that physician trying to make that call. Usually, there's a lot of alignment around initial diagnosis, not always, but usually in terms of what the first treatment should be. So physicians are often fairly aligned with what the payer might consider. And so that person begins, whether it's a 40-year-old therapy or a 1-year-old therapy, they begin that therapy. The question to your point is, what happens when a patient is not responding or is getting worse, is relapsed? And that's the point at which there often is a lot of disagreement about what should come next. And, the frustrating thing for us is knowing that because of the black box of the PBM reimbursement system, it's hard to know when a PBM says, no, you should actually, disagree with you, physician, you should actually go with a different therapy. What's driving that decision to go with that different therapy? Because obviously the clinician is seeing the patient, they're seeing the patient's levels, they're being able to do a physical exam with that patient, and they're being told by, a payer that, like the PBM, no, we want you to do this other therapy. And it usually takes hours, if not days, for that clinician to actually talk to someone who is a hematologist oncologist in our space, which is the specialty that a blood cancer patient needs, to actually have a peer-to-peer discussion about what's causing that delay in issuing that therapy that the physician really thinks is necessary for a patient who is relapsed and is going through a lot and needs urgent therapy. So we see that frustration a lot from clinicians because it does take so long to jump through those payer hoops.
So you've talked about the black box a couple of times, Brian. So how would you explain this sort of follow the dollar of sort of that interaction from the manufacturer to the point when it gets to patients? If you're talking to a new member of Congress, and we know we'll have a number of those in January, how would you talk them through that component? Sort of, where does the money go, and where is this profit margin being perhaps inappropriately leveraged?
Yeah, it's a good question. I wish I could explain it better because there's a lot we don't know, hence the black box term. But I think, the crazy thing is there are so many different points and people kind of between brand manufacturer or even a generic manufacturer making a drug and that drug making it to the patient, whether that's being infused at the clinician or being delivered at a retail pharmacy. There are so many different middlemen in the process. A lot of them are now, as we said, vertically integrated. So sometimes they're all essentially versions of the PBM, but there are folks in between, and money is often flowing both ways at different levels, and that's what gets really, really complicated. But the concerning thing for us is, again, that this money flow, going out 3 different ways, back 4 different ways, out another few ways, all between the process between that drug getting from the manufacturer to the patient, means that the incentives aren't usually patient aligned. The incentive isn't to just make that patient as healthy as possible for that person to live a full life. The incentives can be different for different middlemen along the way in a way that is actually, not aligned with patients and problematic for folks who want a patient-centered healthcare system.
Thank you. So a question for any of you who may want to answer. I think about all of the work that you do and certainly that our industry, is focused on in terms of advocacy here inside the Beltway. And it often feels like we're playing whack-a-mole. And so one of the sort of whack-a-mole issues that I know folks have really leaned in on is around accumulators. And I wonder if any of you would like to talk a little bit about sort of the role of accumulators. And maybe I'll start with you, Anna, and some of the actions that have been taken to date.
Sure. I have a lot to say on this topic. This is something that first came on our radar around 2016, 2017. So in the grand scheme of things, it's a fairly new practice that we believe was initiated by the PBM industry. But essentially, what they're doing is trying to curtail the use of copay assistance by not allowing copay assistance. In this case, oftentimes it is brand manufacturer assistance to count towards a patient's cost sharing. And there are a number of reasons why that's problematic, but one of them is that patients don't really know what they're signing up for. These are not sold to patients in the way that they're experiencing the impact, or to employers who are embedding these practices into their health plans. Oftentimes they're billed as cost savings and that sort of thing, and they can be. However, if you're a patient who is on, let's say, a 20% coinsurance of a $1,600 a month drug, that's a lot of money. And so because of the just general broken nature of the cost sharing structure right now, patients often have to rely on a manufacturer or some other third-party assistance to afford their copays, right? So if you've exhausted your cost sharing or your copay assistance, and you have, let's say, a $5,000 deductible, you are now having to pay the full list price of your drug until you reach your deductible or your coinsurance, which can also be in the hundreds or even thousands of dollars. So we know from both patient stories, data, surveys that we've done, that oftentimes that creates a pretty significant access barrier. Patients are going to try to switch medications, which we know is not clinically advisable. They're going to just abandon their script altogether. I mean, just things that you don't want patients to be doing. So we're really trying to limit the sort of use of copay accumulators, and we've really had a lot more success at the state level. Similarly to the Safe Step Act, we are building support at the federal level, but really it's at the state level where we're seeing that success in ensuring that copay assistance can count towards, a patient's out-of-pocket costs. And I think there are several talking points that the PBM industry is using that we just think are sort of false narratives. And one of them is that, copay assistance really incentivizes patients to use brand drugs. But I would argue that in my therapeutic space, there are not generic alternatives. And even where you have biosimilar medications, a lot of the PBMs are requiring patients to use the brand drug, to step through the brand drug before they can access the biosimilar. And it goes a lot to what Brian was talking about earlier with linking fees to list price. And so PBMs have an incentive; they can extract higher fees or higher rebates from preferring the brand drug. And so it's just, you're seeing this really misaligned incentive structure, and patients are clearly getting caught in the middle.
And earlier this year, you were part of our coffee chat where we talked about accumulators and the great work that has been done by Carl Schmidt and HIV Hep B to really take forward the legal case on accumulators and the decision really that came down in favor of patients, but it's not being enforced. As you or any of your colleagues on the panel look toward the next administration, what are folks' thoughts on enforcement? Is that something that is more likely, less likely? And how would that impact patients?
That is a great question. I'm not sure I would take maybe a 50-50 on whether it's more or less likely in the next administration. I think what we're trying to do is build incremental support towards enforcement, and I think the states have a big role to play here. Certainly, we've had a lot of support from federal members of Congress, the sponsors of our Help Copays Act bill, really putting pressure on the administration. I think, what the administration, this current administration has done is to say, we're not really, enforcing the court ruling at the moment, but, we are going to address the whole issue of cost sharing and how you define that in future rulemaking. So that's kind of the limbo that we're in now. In the meantime, there are some states that are requiring enforcement of it through, their rate filing process. A couple of states have done this, so now we're trying to just kind of build support and awareness of that for other states. And as we explain it, to regulators, I think, you can oftentimes see that kind of aha moment happen. And California is a great example of this, where they actually talked about, enforcement of the court ruling in their comments to the most recent Notice of Benefit and Payment Parameters letter, which was great. So it's like sort of like little things, but that we hope will add up to a broader sort of, pressure campaign on enforcement in the future.
Thank you. Thoughts from either of the other panelists on that?
I will just say I'm with Anna that I think it's 50-50 on where we find ourselves. I think, there's so much. We always say personnel is policy, and I think we're waiting to see, the Trump administration, who is in which roles, to understand, what their mentality might be on enforcing this ruling in question in particular, given the punting that's really happened in the Biden administration. So I think time will tell. We'll see, these rules over the next year or so, but definitely something we're going to be paying close attention to, but one where it's hard to know where the winds are blowing right now.
Yeah, certainly. And I know for folks on the line, we are kind of, it may feel like we're hopping topics, right? Going from PBM, step therapy, talking about accumulators. These are all, in fact, quite interconnected and really all speak to challenges that patients face with regard to being able to afford their medicine. So I think one question I'll toss out there is that what we're hearing a lot more about in the last couple of years is alternative funding programs, these AFPs. And I wonder, is that an issue that any of your organizations have been tracking? And if you have thoughts on those?
I don't know who wants to handle this one first. I mean, this is, well, Michelle, you mentioned earlier that, sort of as we make progress in one area, PBMs and kind of other stakeholders will find other ways, like more insidious in this case, ways to respond. And I think alternative funding programs are one of those where you're basically just carving out the benefit completely and saying, this class of drugs, you patient X are uninsured for this class of drugs, and then forcing patients through, third-party assistance programs or manufacturer programs as uninsured in order to get access to that drug. And unfortunately, we're seeing this practice grow, and even really large employers are starting to utilize these practices. So we are tracking it. It's very difficult to get the actual kind of patient story. A lot of people will ask for that because as a patient, you don't really understand what's happening to you, right? And we've seen that with accumulators as well. It really requires having a conversation and being able to kind of pinpoint as a policy person more so than the patient being able to kind of connect the dots on their own and know what to do in response. So it's something that's very troubling, something that we're very much following. And there is a task force of patient groups, many of whom are represented here, who are really taking the lead on that.
Thank you. And again, for folks on the line who may not be as familiar with AFPs, alternative funding programs, I think Anna explained it quite well. You may not have coverage for a specific medicine, but your plan maybe sold kind of a package by an AFP who's promising that the plan or the employer plan, look, we can still get your very expensive patient, their medicines that they need, but at a much lower cost. And so, again, these third-party facilitators that are putting patients essentially into the compassionate or the patient assistance programs at manufacturers. So really an abuse of the system, and to your point, copay assistance foundations are seeing this a lot as well.
Michelle, I would say that, our perspective is that those are like just patently illegal. It's pretty clear cut. They've just kind of invented a theory of what, based on pretty much nothing in terms of what the statute says about, what's expected of employer coverage in terms of what's a prescription drug and what's that benefit and essential health benefits. I think we are trying to leverage the situation. I'm sure Anna and Pat are similar. We're trying to leverage the situation where actually right now, the payers are kind of on the patient side and saying these are bad ideas. Blue Cross Blue Shield is out there talking about how these are not good alternatives. Or like you as an employer trying to pick plans should not incorporate these. Essentially, it's like it's too good to be true, and there's a reason for that. I think I'm afraid that we're gonna, if we don't leverage this moment and don't get policy action soon cracking down on these, clearly calling them what they are, then we're going to run into where we have been on junk insurance, where the payers used to be with us, but eventually the payers just say, all right, well, this is the game in town. We're just going to incorporate that into our business model. And then they move to a different sector or a different kind of place on the game board than us. And they decide that they're going to be advocating for these things instead of against. So right now we have kind of, I think, a real unanimity amongst healthcare stakeholders that these are ridiculous, that federal lawmakers and regulators need to crack down on them. And hopefully we take advantage of that as quickly as we can so that we avoid the situation where that coalition starts to fall apart and we see these become more ubiquitous.
Thank you. Yeah, I mean, it's again, sort of it's an unusual alliance of stakeholders, but one that's important and really speaks to the significant challenge that AFPs bring forward. I'll turn a little bit, all of you were so active in terms of Part D, and while certainly the IRA has multiple challenges in terms of future innovation and patients really being able to rely on getting a medicine that they need. But there are also the silver lining. I think the patient advocacy community has really driven that out-of-pocket cap in Part D and the smoothing benefit. So could you talk a little bit about that, both the out-of-pocket cap and the smoothing benefit, and sort of what your organizations are doing to educate the community on opting in?
Sure, Michelle, I'll jump in on this one.
Sure.
So certainly the MapRx Coalition has done a lot in working with both Anna and Brian and a lot of other patient organizations to help get us to the point that we're at now with the $2,000 out-of-pocket cap, with the ability to opt into smoothing, to spread costs out over the course of the year. So that was, those two things were really driven by the community, and their implementation is really something that we've focused on as a patient community, and certainly as a MapRx Coalition. We've been very, very engaged in both working with CMS to make sure that implementation goes as smooth as possible, no pun intended there. And that people take advantage of these, particularly the ability to smooth, take advantage of that option. And the challenge right now that I think we face, and Brian had mentioned it a little bit earlier, is people don't know about it. And we're almost through open enrollment, but people don't know that this new option exists. And so a lot of our efforts have been around educating the broader beneficiary community and those that assist them, whether it's the state health insurance assistance programs, whether it's family members, whether it's physicians, and really educating the broader health community about the opportunity to smooth costs. So the MapRx Coalition has produced a lot of different resources, including an overall guide to Part D and open enrollment and how to choose a plan and the things to look out for, and not to, we really encourage folks, don't just look at the premium, look at the benefit. But we also have additional materials such as an infograph, such as an FAQ about smoothing, how it works, because it is a little complicated. It's not as straightforward, and there are times in the year to opt in, particularly early in the year, where it's more beneficial than later in the year. But it's been a huge challenge, working with CMS to make sure that CMS and the plans are making people aware of this. I think there have been a lot of challenges there, and then a lot of it's fallen to us as a patient community to educate the broader healthcare community about smoothing and about the cap. So there are two huge victories, and there's certainly some challenges that come with those, including some of the rise in utilization management, some more access barriers. But these two things that we advocated for are critically important to helping affordability, helping ensure that people are accessing the medications that they need.
Thank you.
I'll just add quickly to that. I just reiterate. First of all, I can't recommend MapRx's suite of materials enough. So I think folks should leverage those if they haven't had the capacity internally to use those to educate their community yet. But I do think it's going to be educating providers. It's going to be so important to this process because there's so many newly diagnosed people and so many people who really only engage through their provider. And providers need to understand that this is an option for folks so that they can get them enrolled and beginning in that process before they go to the pharmacy. Because what we've learned through the rules so far, in at least year one, if you go to the pharmacy and you're not enrolled in smoothing, you have to wait about 24 hours to be able to get the benefit. So you have to essentially go home. And that is not patient friendly. So really we need to get folks enrolled at the very latest, enrolled at their clinician. And so that's why I think, one of the reasons why I think it's so important that we all work to get our providers brought up to speed on this and their role in it so that they understand that and communicate it to their constituencies.
Yeah, and the other thing, I'll just jump in on that. Sorry, Michelle. Just one quick thing on that is that the ability to smooth, people can opt into it throughout the year, so it doesn't end at open enrollment. So that really reinforces what Brian was just talking about, the importance of education and educating providers, and also the importance of advocacy. We're certainly going to continue to advocate for point of sale option, for the opportunity to enroll via the Plan Finder, Medicare Plan Finder. So. A lot of other advocacy to take place in addition to the education piece.
Thanks so much. So as Brian mentioned earlier, educating the providers and the importance of that. Have you seen that taking place? And if so, where and who's doing it well?
That's a good question. I think we are trying to do it. Hopefully, we're doing it well. We have both at the Leukemia and Lymphoma Society. I'm sure a lot of folks are organized similarly, but we have clinician education. So we provide continuing education credits. We do like rounds. We do all kind of hosts of clinician-facing educational kind of opportunities where we can ingrain this into what we're teaching. And so I know that's part of what's been our method. Also, we've just been going to the kind of our counterparts at our big societies and talking with them about the value of this and trying to encourage them to share this with their members and impress upon them just the importance of making sure this is incorporated into their day-to-day as they're dealing with patients. So I think that's a big part of it. And then we do local events like we call the blood cancer conferences. We get together, you have clinicians, you have patients, you have caregivers, they come together and learn about cancers, and there's a whole different suite of things they can do throughout the day. But those events are real opportunities for those providers who are interested enough to come to that. We are educating them also on this as something important for them to think about. So we're trying to throw all the spaghetti at the wall with our clinicians. Hopefully it sticks, but it's definitely something that's going to take a group effort.
So from a patient perspective, from any of your organizations, what concerns do you have about plan behavior as a result of the restructure? How do you anticipate things might look different in the future?
Yeah, we're very concerned about plan behavior, and particularly whether it's formularies and more narrow formularies, whether it's increased utilization management, things like prior auth and step therapy. Very concerned about that. MapRx produced a paper on this over the summer, talking about some of the challenges that we anticipate, and I think we're going to see. So that's something that we need to make sure that we're vigilant on, and that we're engaging CMS and creating a feedback loop with CMS, so that they understand and see the challenges that we're having, and that there are guardrails and adequate oversight to make sure that any new barriers or existing barriers don't unduly restrict patient access to medication and kind of undo the benefit of the out-of-pocket cap, of the ability to smooth, which address affordability questions. But we still have these other access barriers, and we can't create these new benefits for people at the same time undermine them with additional access barriers.
Yeah, sure. I mean, of course. So a question that's probably on all of our minds right now, there are only a few weeks left of this Congress, and we've come so close to passing PBM reform. What are the prospects of getting something over the finish line this year? How are you feeling about that? And Anna, I'll start with you since you mentioned the package.
Okay.
Yeah.
Well then, let's see. I have to go, so I did 50-50 on my last one. I'm going to go, oh gosh, more like 20-80 that we're not able to get comprehensive PBM reform done in the few weeks that we have left. I think, with the outcome of the election and then the various things that do have to get done in the next few weeks, it seems less likely to me. I would be very interested in Brian's take on this because I think he's been a lot more engaged on some of the individual components of PBM reform over the past couple of years. But each committee has done kind of their own thing, and some have been bipartisan, some not as much. But I would anticipate that the kind of incoming majority in both houses are going to want to put their own kind of stamp on it, and whether that then means that we prioritize certain of the more bipartisan pieces of it early in the next Congress seems to be kind of up in the air. And certainly it seems like, every day there's kind of a new take on what the chances are and what the priorities are and things like that. So I hate to prognosticate, but I'm being a realist here, and I don't think the chances are terribly high, but you never know. I always go back to the example of the No Surprises Act, which I think at this point, a few years ago, none of us thought were going to happen in that Congress, and it did.
I can pick it up from there. Since Anna shouted me out, I do think she's right. We're under 50%. I think we're a little bit north of 20% at odds that it goes. But I do think, and that's just because of the size of the package. It seems like folks are thinking an end of year package is going to be smaller. It's going to require fewer offsets of pay-fors, and this is one of those pay-fors. It's definitely in the mix, and so that's why, to Anna's point, we don't know. We just don't know until it comes together. We don't know whether it'd be a 200-page package at the end of the year just to punt everything to March, or whether it's going to be a 3,000-page package because retiring members just want to put their stamp on things before they go out. So I think we are waiting to see where that goes and seeing where we fit in there. But I do think just to everything that Anna just said about how bipartisan this has been, how bicameral this has been, how much stakeholder support there has been for PBM reform, including from even some payers and from some employers, but lots of employers. I think the diversity of the coalition here has meant that even if the odds went down a little bit and on the lame duck PBM reform package, I think they went up on a PBM reform package, a big one potentially happening in the next year or so. So I think there's no wasted effort in this time where we're trying to get Congress to act now, and then we'll hopefully have a lot of successes next year if we don't see it in December.
Yeah, that's a good point. There's some good pay-fors in there. I think delinking alone between the commercial and Medicare markets is north of $1 billion. So that's an excellent point.
Yeah, and I'll kind of split the difference between Anna and Brian in terms of the odds. But I think we have the opportunity. The opportunity is still there, whether it's in the lame duck or in the new year. But we need to continue to get the message out there. And really, again, I'll go back to what I said earlier about humanizing this and really putting a face on some of these issues and how they impact member constituents in human terms. Because there's Brian was talking about the black box and how it works. It's a very challenging thing to explain, but putting it in terms of a person living with lupus or a person living with RA or leukemia, that's a little bit more easier to understand. And I think we need to make sure that we're not letting up our efforts, our advocacy efforts on this. We still have a chance in the lame duck, and we should continue to push for that.
Excellent. Well, thank you all so much for this conversation. It has been really enlightening, and certainly appreciate all of your leadership. I know that your call to action is really for this reform and supporting your grassroots in voicing that with their members. So we certainly hope to see something this Congress, and if not, we will stay optimistic on the next Congress. But thank you so much for joining us to talk about PBMs today, and we will certainly wish you all a very happy holiday season.